Trouble with your valves. We're not talking about your car or your plumbing. We're talking about your heart. Welcome to Talking with Docs. I'm Dr. Brad Wiener.
I'm Dr. Paul Zalzal.
Brought a guest today, Dr. John Chuback, to talk about valvular heart disease, which is a really common topic, a very significant and debilitating problem, but has some really great solutions thanks to modern medicine. Welcome.
Welcome, and thanks for being here and teaching us about the heart valves.
Okay, so let's talk about what a valve is, where they are, what they do, and why they fail.
Well, the human heart has 4 chambers and 4 valves. So we can play a little game that we used to play when we were residents, which is make believe you're a red blood cell.
All right.
So if you're a red blood cell returning to the heart, you have 2 ways of getting there. One would be through the inferior vena cava, and one would be through the superior vena cava, depending on where you're coming from. But you're going to wind up in the right atrium, the upper chamber of the right side of the heart. And from the right atrium, you're going to travel during the atrial contraction. You're going to be forced through the first valve, which is the tricuspid valve on the right side of the heart.
Which has the most explanatory name, ironically, of all 4.
Yeah.
I'm like, okay, here it is. It's a tricuspid valve. This is called tricuspid valve. It must have been the first one that they found.
And they failed to mention that 2 of the other ones also have 3,
Right.
3 cusps.
Right.
So they got kind of gypped on their
Yeah.
names. But so you go through the tricuspid valve, which is what we call an atrioventricular valve, separating the top chambers of the heart from the bottom chambers of the heart. And now you're floating in the right ventricle. And with systole, meaning the contraction of the lower chambers, you as a little red blood cell will be pushed out through the pulmonic valve or the pulmonary valve, which is also a 3-leaflet valve, into the pulmonary artery. And this is you like this kind of stuff, Paul. This is a little
Love this stuff.
Esoteric bit of medicine. At this point, you're a red blood cell, but you're deoxygenated. You've unloaded your oxygen. So you're blue blood.
I'm blue.
You're blue blood.
Mm-hmm.
So this is one of the only times where blue blood is traveling through an artery.
Great med school question.
This is a good board exam question or med school question.
Yeah.
So, and why? Because arteries take blood away from the heart. So it's deoxygenated blood, but you're going away from the heart. You're going out to the
Because
lungs.
usually arterial blood is red and rich in oxygen.
Exactly.
Okay.
So now you go out to the lungs, you pick up some more oxygen because you're going to unload that to the tissues out in the body. And now you get to, you go through the pulmonary veins.
Mm-hmm.
Now you have oxygen, but you're going in a vein because you're heading back into the heart. So arteries away, veins in, IN. So now you go to the left atrium and you're in the upper chamber of the left side of the heart. And that contracts and you go through the mitral valve, which is the left-sided atrioventricular valve. This one has 2 cusps.
Bicuspid.
Okay, anterior and posterior valve, bicuspid valve. And you go into the left ventricle, which is the big pumping chamber of the heart.
And here's where you've gone from low pressure, now you're in a high pressure situation.
Correct.
It's the other big change in the heart.
Absolutely right. And now you're full of oxygen, you're in the left ventricle. The left ventricle is a big muscular portion of the heart, and it squeezes, and you're ejected under high speed with a lot of force and flow through the aortic valve, out into the aorta, and then you're free to unload your oxygen anywhere that you might wind up in the body.
And none of this could work. None of this blood flow, none of this pumping, none of it could work without valves that work.
Exactly.
Because the valves are the one-way ticket that lets the blood go one way and not back the other way.
That's the key. These are one-way check valves. They open in one direction, allowing blood to fire through, and then they close nice and tight. They slam nice and tight. And the way I'm showing is exactly, this would be a better representation, how the leaflets of the valve perfectly what we call coapt. They come together just perfectly to seal that chamber, open, close, open, close.
Like a saloon door if it went all the way to the floor and to the ceiling.
Exactly. And that coaptation and that function of the swivel mechanism, the hinge mechanism, and the closure mechanism is just exquisite, I have
Yeah.
to say. Human
That's pretty
anatomy
amazing.
and nature, it's beautiful.
What was not so exquisite was me using the valves around our home filter system when I was trying to change the filters. There's a sequence there that you got to do that I failed to recognize
Yeah.
before water went everywhere, but there's like about 4 valves around that thing. And it really does control the flow.
You'll have the same problem in the heart
That's
if those
right.
valves aren't functioning
And I,
properly.
and I think that's a nice segue to talk about kind of the two most common types of valvular heart disease. So you can either have stenosis, where that valve gets too tight and doesn't allow the blood to flow out at a normal rate, or regurgitation, where it doesn't stop that backflow.
That's right.
So can we talk a little bit about the differences of those two things and what causes these problems, John, and where it most commonly happens?
Yeah, well, the pulmonic valve will leave aside. It can have problems and it sometimes gets treated. Probably the two most important valves in terms of valvular dysfunction and valvular repair are certainly the aortic valve and the mitral valve.
Right.
Maybe a little bit about the tricuspid valve as well, but aortic and mitral we can, I think, focus on. And as Dr. Winning mentioned, the two main categories of problem are stenosis, where you have a valve opening, which should be nice and large like that. And then for a variety of reasons, there are many reasons that can cause this, but let's say the aortic valve, the most typical problem is just aging.
Yeah.
And with age, calcium builds up and you get calcification. And that valve, the little leaflets that are very, very delicate, if you could think of, I want to say like tissue paper, but it would be more like raw chicken skin, believe it or not.
Okay.
Thin like that, a little bit rubbery and elastic, and very supple and floppy and nice and soft. Those begin to develop calcium deposits, which leads to more inflammation, and those leaflets begin to get deteriorated, shrunken, hardened, thickened, and that can lead to aortic stenosis, a narrowing of the aperture or the opening of that valve. And when you get that, then it's harder for blood to flow through it, and it also makes the chamber behind it, which in the case of the aortic valve, the chamber behind it is the left ventricle, makes it work a lot harder in order to force the same amount of blood through that smaller opening.
And we see these in our pre-op patients because sometimes they do have aortic stenosis, and once it hits a critical point, it becomes very high risk to do surgery until that aortic stenosis is treated.
Right, and aortic stenosis can be deadly, and it's one of the most common causes of sudden death in people when they don't know that they have it.
And when you talked about causes in calcium deposition, this is really just age-related. It's not because you eat too much calcium. Sometimes it can be related to high blood pressure, obviously. The amount of force and essentially damage or stress on that valve can cause some problems. But usually the stenosis itself is just kind of age-related and it's just slowly progressive, not something specific that you can really do to stop it. Is that fair to say?
Yeah, I would say that that's right. And it definitely, we see it as age advances into the, certainly beyond the 60s, into the 70s, 80s, and even 90s. And that's why aortic valve replacement for aortic stenosis, what we call AS, has been one of the few places historically where we did open heart surgery on people well into their 90s. Because if they were otherwise in good shape and they had a good ventricle, or if their ventricle was beginning to show signs of failure, we knew that replacing that aortic valve could be life-saving, because when you open that up, your heart just loves it. It just sings along, and suddenly, especially it's gotten strong from pumping through that tight opening. Now you have this nice strong ventricle, and it's really supplying your body with a tremendous amount of blood flow. So it's a great thing.
And often these are picked up just with a stethoscope, right? You can hear these. Typically, these.
Well, when we were boys, that was true. But
Yeah.
yes, hopefully people are still listening with a stethoscope
Well,
and examining patients. But the murmur that you get from aortic stenosis is quite
Even an
dramatic.
orthopedic surgeon could hear it.
Exactly.
I remember thinking that, I like AS. I like
Yeah,
this.
you can hear
It's
it.
great. It's like, shh,
Exactly.
shh. It was great. It was nice. You didn't,
Yeah,
Exactly.
we should talk about the onomatopoeia of it all, right? You got the lub dub. Those are the valves you talked about.
That's right.
Lub is the first heart sound. That's what we were all taught. And that one is that lub is the mitral and tricuspid, I think it was.
Correct.
And then dub, the second one you hear, that's your aortic and pulmonary
Correct.
artery. So lub dub, it doesn't really sound like lub dub.
No.
It's always like a thud thud.
Mm-hmm.
And then the murmur, which is also onomatopoeia.
right.
You can hear when something's wrong with these valves.
Yes, because normally if you listen with a stethoscope, you shouldn't be able to hear blood flow. You can't. That's what the murmur is. It's abnormal flow. That's what's making
Yeah,
that sound.
or really high output
Yeah.
flow, but typically
Right.
the abnormal
Yeah.
flow.
And today, of course, if somebody has any signs of valvular disease, typically, yes, a good cardiologist obviously knows how to listen to all of those sounds, the clicks, the opening sounds, closing sounds, delays, and all of these kinds of things. But people get an echocardiogram, which tells a beautiful, beautiful story and shows incredible pictures of the heart, how the chambers are functioning, how the valves are functioning, and what they look like.
Yeah, echocardiogram, combination of ultrasound and Doppler ultrasound.
Yeah, and as a patient, you're wondering, well, what am I going to feel? Well, in the early phases, you might not feel anything, but you might feel shortness of breath. You might have chest pain. You might have some swelling, depending on which valve is causing you a problem. But a lot of times in the early phases, you're not necessarily going to have a definitive kind of symptom that's going to send you to the doctor. Is that fair?
That's true. And when you do have symptoms, there is a fair bit of investigation that needs to happen because all of those symptoms that you mentioned tend to overlap with all of the valvular problems.
Sure.
Right. Yeah, I mean, that's the way it is, right? So with valvular heart disease, if you have it or you're worried you have it, you're going to have these symptoms, which are similar to just sort of heart failure symptoms, right? Fatigue, shortness of breath, chest pain, you might get swelling of the ankles. And then screening would be your stethoscope exam by your family physician, primary care physician. They'd also look for other signs of heart failure. And then, like you said, definitively to make the diagnosis, it's an echocardiogram, which is an ultrasound test. There's no radiation there. And that can tell you a lot of what's going on.
And that will show you the stenosis part. But the other one is the regurgitation. We should just talk quickly about that. So when the valve, rather than being narrow, it closes, but it doesn't stay closed, or the doors flap all the way in.
That's your saloon door.
Yeah, that's kind
The
of
saloon door is
the
the
one
one
that
that
kind of
goes
comes
both
back.
ways.
Yeah. So how's regurgitation different than stenosis?
Yeah, aortic regurgitation, what we also sometimes call AI or aortic insufficiency, the original AI, is where the valve, rather than becoming stenotic and small and not wanting to move at all, that valve starts to flop back and forth, as Dr. Wiening said, like saloon doors. And now pressure is coming, high pressure blood from the aorta is coming back down into the ventricle, overloading the ventricle. So the ventricle is being filled from two directions. It's filled from the mitral valve at the atrioventricular, the proper direction, blood is coming in, and backward blood is also going down into that ventricle. And that ventricle is now working overtime to say, oh, why are you guys overloading me like this? It's called overload. And it's working really hard to empty all of that blood out. And over time, it'll start by thickening and what we call ventricular hypertrophy, where the heart muscle, just like any muscle that you stretch, will hypertrophy and grow and get thicker. But if that's not relieved over a period of time, then it will begin to dilate and fail. And when you have a dilated ventricle, that's really significant heart failure, and that's life-threatening, and that can be irreversible in the worst-case scenarios.
Right.
Okay, but the good news is we have the technology to fix these valves when something goes wrong with them.
What are the treatments?
The treatments are basically when you get to critical level of disease. Early on, they're going to be treated medically, weight loss, good diet, management of blood pressure, and all of those kinds of things, sometimes diuretics to unload excess fluid that's building up.
Beta blockers, maybe.
Beta blockers, exactly. These kinds of things. You're also going to look at any correctable other problems, like, for example, ischemic disease. You can sometimes have an overlap of ischemic disease with valvular disease, and sometimes the ischemic disease is the cause. For example, a classic example would be mitral valve disease, which you could have, let's say, a myocardial infarction or low blood flow to the heart muscle, and you could have a papillary muscle rupture, for example. The papillary muscles are beautiful little structures in the bottom of the ventricle that hold these beautiful little tethers. It's almost like a kite. The valve is connected by these beautiful little fibers that we call chordae tendinae, that attach to the papillary musculature. And if that muscle has an infarct or dies from a heart attack, it can break loose, and then you get a floppy valve over there. So you want to treat the underlying ischemia in that case and the valve. So if we get into treating valves
Yep.
from a surgical point of view, that's a very rewarding part of cardiovascular surgery and open heart surgery, which has changed dramatically from the time, for full disclosure, I haven't been doing open heart surgery in about 10 years, but it has changed dramatically from right about the time I was getting out of cardiac surgery until now. And the big change, like almost everything in medicine and surgery, has been toward more minimally invasive techniques. And so we used to do what is now called the SAVR technique, surgical aortic valve replacement, for example, SAVR, S-A-V-R, surgical aortic valve replacement. And now they have the TAVR technique, transcatheter aortic valve replacement, which is a minimally invasive technique whereby the doctors, it's typically a team now of interventional cardiologists and a surgeon who will put a catheter through the femoral artery most commonly, or sometimes even through the carotid artery, believe it or not, to get to the aortic valve, and they deliver a device, amazing biomechanical engineering device. I know Paul's an engineer, that you put right inside of that bad valve, and you basically deploy it and pop it open, and it stays in place, and you move all the bad valvular material. This is
like an umbrella, like it's amazing.
Yeah, like a very strong umbrella, which is hard. When these first came out, it was hard for me to envision that this would actually work, that this could even be possible. But it does work, and I think it's quickly becoming the standard of care, believe it or not. In the beginning days, when I was still doing open heart surgery, it was being really reserved for people who were very, very sick, advanced age, in their 90s and so forth. But little by little, the technology has gotten so big that it's replacing open heart surgery, which is a big, big operation. It's mostly reserved for aortic stenosis and not so much at this point for aortic insufficiency.
Right.
All right, so there you have it. There's sort of what you're going to be feeling if you have a valve problem, how it's diagnosed, and some treatment options for you. That's pretty much valves of the heart.
Yeah, I think the most important thing is if you have a heart problem, it's not always you're having an impending heart attack. It can be the valves. See your doctor. If you have chest pain, if you have shortness of breath, if you have swelling in your legs, get this investigated to get it properly diagnosed and maybe even dealt with on the front end so you can avoid some of the downstream complications. But like we've always said, you are in charge of your own health, and you have to advocate at times when everyone is busy, including your doctor. You need to advocate for yourself, get seen. And most importantly, if you like this video, please like it, subscribe to our channel, share it with someone that you think may benefit from something about valves.
And remember, you are in charge of your own health. Thank you so much for watching, everybody, and thank you, Dr. Chuback, for sharing your expertise.
Thanks for having me, guys.
Thanks for coming, John. We'll see you next time.